Hi, everyone. Thank you so much for joining us. My name is Julia Mayetta. We are so pleased that you could join us for this week's lecture in Volume 2 of our 12-week No Neuropsychology Didactic series that brings you lectures from experts in the field covering a variety of topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. We would like to thank our sponsors for their financial support of this series. Before we start, here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box, which is on the lower left-hand corner of your screen, and a recording of today's lecture will be provided on the website later this week. We will address questions to the speaker at the end of today's talk. Now it is my pleasure to introduce Dr. Donna Broschek for today's lecture on identifying and treating persistent symptoms after concussion. Dr. Broschek is the John Edward Fowler Professor at the University of Virginia School of Medicine. Her primary appointment is in the Department of Psychiatry and Neurobehavioral Sciences, where she is Director of the Neuropsychology Assessment Clinic and Chief Psychologist. Clinically, she sees a large volume of patients recovering from concussion and moderate to severe traumatic brain injury, as well as patients with epilepsy. She works closely with the UVA athletics program and is a member of the Concussion Committee for the National Basketball Association and the WNBA. She is also a consultant to the U.S. Olympic and Paralympic Committee, and she is a fellow of the National Academy of Neuropsychology and the Sports Neuropsychology Society, as well as past president and executive director of Sports Neuropsychology Society. Donna Broschek is the chair of the Sports Neuropsychology Special Interest Group of the International Neuropsychological Society, and additionally, she is a member of the Professional Advisory Board for the Epilepsy Foundation. Dr. Broschek has been active in research in sport concussion and has published peer-reviewed articles as well as book chapters on the topic. Dr. Broschek has also been active at the local, regional, and national levels in promoting concussion education and safety. So we are very pleased to have her here to talk about sport concussion and concussion in all areas. So I'm going to stop sharing my screen.
All right, and thank you so much for that introduction, Julia, and also to Lucas and the rest of you for this invitation. And now I'm going to try to share my screen. Okay. Give me 1 second. Okay. Does that work? Can you see that?
Not yet. It doesn't look like it's up quite yet.
All right. And now can you see those? Excellent.
Yeah.
I was saying to the folks on the call, as we were waiting for you all to sign on, I've had a number of Zoom disasters recently and WebEx disasters and things like that. So I'm always prepared for technical difficulties these days. So, but welcome to you all. And I'm going to be talking today about persisting symptoms after concussion. And just in terms of disclosure, my main disclosure is I am now getting some compensation from the Sports Neuropsychology Society's executive director. But everything else you see there is uncompensated. So my disclosure is that I'm not very good at getting compensated for work. But what we're going to talk about today is I really want to cover concussion basics. And I'm going to really drive home a couple of points today, which is that understand that post-concussion syndrome is not a helpful or informative diagnosis. I'm going to advocate for new terminology for symptoms after concussion. And I want to talk about how multiple individual factors can influence recovery. And also really stress the importance of understanding it's really critical to have an individualized assessment so that athletes and patients can be managed who have prolonged symptoms. So concussions are not just football. And they're not just from contact sports. They're not just males or organized sports. Here in Central Virginia, we see plenty of equestrian injuries, and then one of my new nemesis are the scooters, for which we certainly see some concussions and more serious head injuries. And it's really important to realize that it's not just sports or recreational activities. We know in particular that older women are at risk for falls, our female service members are at risk, and of course car accidents, and then partner violence can also be a source of concussions and more severe brain injuries. Here at UVA last spring, when our basketball team won the NCAA championship, we had these kinds of activities, and some of those could result in concussions as well. So just to kind of orient you, I really want to talk briefly, you may have seen this. So when we talk about the spectrum of traumatic brain injury, it goes from mild to moderate and severe. And a mild traumatic brain injury means typically that standard clinical imaging, MRI, head CT is negative, and that any loss of consciousness that occurs is 30 minutes or less, and that if there's an alteration of consciousness, it's up to 24 hours. Post-traumatic amnesia, which is that difficulty in coding new memories, can last up to a day. And that if there is a Glasgow Coma Scale score available, that it's a 13 to 15, so indicating a mild injury. So when we talk about concussion, a concussion is really a mild traumatic brain injury. Many of the individuals that we see after concussion have no loss of consciousness or very, very brief loss of consciousness, very brief alteration of consciousness, short PTA as well. And so typically a concussion means a mild traumatic brain injury. And so the most recent agreed upon definition of sports concussion is the one from the International Consensus Conference in Berlin in 2016. And I think this is actually a really nice definition because it really lays out some key areas of misunderstanding. So if you look at this definition, you see that sports-related concussion is a traumatic brain injury induced by biomechanical forces, and there's several common features. One, that it can be caused either by a direct blow to the head, face, or neck, or elsewhere on the body, and that's really important. Sometimes people can get a concussion without actually even being hit in the head. A classic example of this is if you see in football, and for instance, you might see a receiver, and then you see another player really tackle him and kind of really hit him hard in the chest, and then you see the head snap back, and that can be enough to cause a concussive injury. A sports-related concussion typically results in the rapid onset of short-lived impairment of neurologic function that resolves spontaneously. However, in some cases, signs and symptoms evolve over time. So at the moment of injury, they may not have their most severe symptoms, and that may evolve over typically a few minutes, but it can be up to hours. And then it's really important to recognize that sports-related concussion may be due to a neuropathological change, but typically it is a functional disturbance rather than a structural injury, and I'll show you a slide on this in a minute. And again, as I was mentioning with concussion, there may or may not involve a loss of consciousness. And this is a misunderstanding that some people have. You can definitely have a concussion and not have had a loss of consciousness. And having a loss of consciousness does not necessarily mean you have a more severe injury, depending on the length of loss of consciousness. And this is a really important caveat, which the clinical signs and symptoms cannot be explained by drug, alcohol, medication use, other injuries such as cervical injuries or vestibular dysfunction, or other comorbidities, so psychological factors or coexisting medical conditions. And so, for instance, if you think about a car accident and if somebody's inebriated, it can be very hard to tease out the effects of inebriation versus a mild concussion. And so when we talk about concussion, what we're talking about are these very acute symptoms that typically you see right away. So that classic lack of awareness of surroundings, confusion, nausea, vomiting, headache, dizziness, some memory problems, and vertigo. So many people who work with athletes in particular and are on the scene say, the eyes tell a story. So you can typically see that very vacant gaze. And also the signs and symptoms tend to cluster. So there are somatic symptoms, of which headaches are predominant typically. The cognitive symptoms that we in neuropsychology are often called in to evaluate. Sleep disturbance is very significant and can be quite a problem for concussion recovery, and we'll also talk about that a little bit more later on. And then mood issues, which can be triggered by a concussion. So as I mentioned, Chris Giza and David Hoft at UCLA, this is their classic slide of the neurometabolic presentation of concussion. And what it really shows is that there's just this cascade following traumatic brain injury. It affects the action potential, potassium and calcium distribution. And so essentially what this does is it creates an energy crisis in the brain. And this is what's happening when people start to experience the symptoms and feel highly symptomatic. The other thing I really want to stress today, so as we just saw, it's really a neurometabolic issue. And so I often use the analogy of a snow globe. If you take a snow globe and you shake it up and everything's flying around, that's kind of the peak neurometabolic cascade. And as the things in the snow globe settle down, the symptoms start to remit and a person starts to feel better. And so it is a curve with the highest symptoms initially, and then they start to taper downwards. And so we previously used to say that people should not engage in any activity until their symptoms have completely resolved. And based on research, we now know that actually can delay recovery and it can actually cause prolonged recoveries. And so in the Berlin meeting in 2016, the progression of how you manage somebody's symptoms was changed. So instead of saying, wait until somebody was symptom-free and then start to introduce physical activity, the new guidelines are you start symptom-limited activity not too long after the concussion and not too long in the next day or so, 2 to 3 days. And what that means is their daily activity. So don't say, go stay in your room, don't open a book, don't talk to anybody, stay off your phone, because that actually can create a lot of iatrogenic effects. That creates depression and deconditioning, and it can really make people feel worse. So what you want to say is you can start to reintroduce your daily activities as long as they don't make your symptoms a lot worse. And then this is specific to athletes. So once somebody can do that and they're feeling okay, then you introduce light aerobic exercise, such as walking, stationary cycling. And then you start to introduce sports-specific exercise with various running and skating drills, non-contact drills, and then you can progress to full contact practice or return to play. And what this chart describes is that after a diagnosed concussion, this means an athlete should not be back in the game for 7 days at least, because each of these steps is typically a minimum of 24 hours and sometimes longer. And Chris Giza, who's a pediatric neurologist, has also said that for children and adolescents, you should really expand this. So each step should really be more a minimum of 48 hours and maybe longer, because you definitely want to be more conservative with your younger athletes. And this is the from the CDC, because I always like to show that this is not just one source, not just Berlin that says this, but the CDC had a very large group of experts, which included many of our neuropsychology experts, who reviewed the literature and came out with new recommendations. So this is all on the CD website, and they have wonderful resources. And what they said is counsel patients to return gradually to non-sports activities after no more than 2 to 3 days of rest. So these are for pediatrics. And the idea is not to focus on return to sport, but to get them back into school, get them back into doing the things that they normally do day to day. And as they start to recover, and then when they can do their regular daily activities, including school, and their school work, then they can progress back to sports. But the idea is not to just hold people and keep them not doing anything until all of their symptoms are gone, because chances are they're going to have a really prolonged recovery in that situation, because activity actually helps with recovery when it's introduced appropriately. And so I want to talk a little bit about all of the factors that may be associated with persisting symptoms of concussion, so the predictors of clinical recovery. And many patients, and actually many providers, will say that they've heard that this factor or that factor are associated with prolonged recovery. And so in Berlin, I was part of a work group that looked at the literature on this, and very fortunate to have the group led by Grant Iverson. And so the initial Medline search that was conducted was for concussion and mild MTBI, looking at variables affecting recovery in English. The articles had to be peer-reviewed. It had to be original research with human participants from 1990 and through April 2016. That yielded 43,555 publications. And in the understatement of the decade, Grant said, the problem, as we all know, is that our topic is extraordinarily broad. So we obviously needed to really refine this and come down, find a much smaller number of articles to review using more stringent criteria. What was interesting is that across the literature, there were numerous factors that were identified as potentially associated with a worse prognosis after sports concussion. And these included things like injury severity, which includes seizures, CT MRI, a lot of premorbid factors, including learning disorders, ADHD, education, anxiety, migraines, sleep medications, the age and level of sport played, sex, male or female, genetics, blood biomarkers, history of previous concussions, post-injury, and other factors occurring around the time of the injury. And so as you can see, there were a lot of factors that were explored as potentially associated. And based on the review of the literature, we decided that what was clearly already known at that point in time was that having more symptoms and more severe symptoms right after concussion, that acute period, is a predictor of slower recovery in some studies, not consistently. But typically, anybody who has a concussion, which is a form of brain injury, and has more symptoms acutely, and those symptoms are more severe, are more likely to have a longer recovery. We also know that a large percentage of athletes recover clinically within 10 days, and a large majority recover within 30 days. So that's sort of the typical expectation for recovery. Injury severity characteristics such as loss of consciousness and retrograde or post-traumatic amnesia are not consistent, strong predictors in some studies. The reason is that in sports, a loss of consciousness in particular tends to be either no loss of consciousness or relatively brief. And so that is not as significant of a variable. For instance, in car accidents, you may have somebody who had a mild traumatic brain injury with a loss of consciousness of 15 minutes, and that would be a different type of predictor. So what did we find after reviewing the literature? Primarily, we found mixed findings. So looking across all the literature was very mixed. And in the table that we created for any set of studies that said X was associated with a prolonged recovery, there would be an equal number that examined that and said it was not associated. And so that's part of why this big review is important, is because there are numerous articles that cite factors associated with the prolonged recovery, but when you look across multiple studies that were well-designed, well-controlled, they tend to wash out. Consistently, however, pre-injury mental health concerns and a history of previous concussions does appear to be a risk factor for persistent symptoms. So those are very important variables to be aware of when you're working with anybody recovering from concussion. And as we knew previous to doing this large review, again, greater acute and subacute symptoms are a consistent predictor of worse clinical outcomes. So somebody who has really bad headaches and really significant symptoms is just going to most likely have a longer recovery than somebody with less severe symptoms. We also, based on the literature, believe that the teenage years may be a particularly vulnerable time for having persistent symptoms and potentially with a greater risk for girls. And you'll notice that I've said possibly and potentially, and that's because the data was suggestive but not strongly compelling. So again, it's always important to be more conservative with your child and adolescent patients with concussion. And just be mindful that if it's a female adolescent, she may have a little bit more difficulty, and to be aware and actively addressing that. So one of the take-home messages from today's talk that I really want to make is that myself and some colleagues have been advocating for using a different term instead of post-concussion syndrome. So at the inaugural Congress for Athlete Brain Health Foundation, our work group made a strong pitch to abolish the term post-concussion syndrome and to replace it with persisting symptoms after concussion. And so I'm going to make a case for that because I think it's really helpful to patients and to other providers. So the term persistent symptoms after sport-related concussion has been introduced, and that was in the British Journal of Sports Medicine. And basically they say it's clinical recovery that falls outside of expected timeframes, which is 10 to 14 days in adults and more than 4 weeks in children. However, we think that there's still a better term. And as I get to that, I also want to talk about what's wrong with using the term post-concussion syndrome. Well, if you look at Merriam-Webster, it says a group of signs and symptoms that occur together and characterize a particular abnormality or condition. One of the things that we know about concussion is there are not a clear group of signs and symptoms that always occur together. Even though I showed a lot of symptoms when describing what a concussion is, those don't always hang together, and people have different presentations. And then at American Medical Informatics Association symposium, they described a syndrome as a recognizable complex of symptoms and physical findings which indicate a specific condition for which a direct cause is not necessarily understood. So again, really saying that if you use a syndrome, it really means you don't know what's causing the symptoms. And then the case that we've made for persisting symptoms, if you think about persistent, and again, I go to Merriam-Webster here, these definitions are directly from Merriam-Webster. So persistent means existing for a long or longer than usual time or continuously, continuing, or this is my underline, inclined to persist in a course, continuing to exist despite interference or treatment. So it implies that persistent symptoms are unremitting and unrelenting. But if you look at the definition of persisting, it means to continue to exist, especially past a usual, expected, or normal time. Does not mean it's going to go on forever, that it's going to continue despite treatment. It just means the symptoms are lasting longer than typical or longer than the usual time frame. And I think that's a very important distinction. Persisting does not imply that symptoms are unrelenting, but just longer than typical. And it instills hope, because that is a much more hopeful message for our patients. Hope that they will get better, that they will improve, hope that they will recover, and that they will return to their life, the important activities and the things that they want to participate in their life. So if I go back to why the term post-concussion syndrome is problematic, it implies that a constellation of symptoms, as I mentioned, that consistently occur after an individual has sustained a concussion. There's no clear information about symptom etiology or no information about helping the athlete or patient improve. The other big problem is that symptoms that are consistent with post-concussion syndrome are also consistent with normal life, particular stress, depression, anxiety, other mental health concerns, chronic pain. And one of the things that's really important to be aware of is that post-concussion syndrome, the definition, the symptoms associated with that are extremely nonspecific. And this was a study done by Grant Iverson and several of his colleagues, where they looked at patients with mild traumatic brain injury compared to healthy controls. And they found that 59% of those who had a mild traumatic brain injury met the ICD-10 criteria for post-concussion syndrome at 1 month. So about 59% at 1 month had those symptoms. And then at 1 year, 38% met the criteria. But what they also did is they surveyed a normal, healthy population and found that 31% of the controls who had never had a concussion met the criteria for post-concussion syndrome. And that's because those symptoms are so nonspecific. They also found that there's significant predictors of post-concussion symptoms at 1 month were pre-injury mental health and peripheral or bodily injuries, so typically pain associated or stress associated because they have to go see an orthopedic surgeon or have issues with gait or mobility. Depression also predicted at 1 month as it did at 1 year. And then individuals after mild TBI who had their symptoms at 1 month still persisting tended to be those whose symptoms were persisting at 1 year. So really showing the importance of early intervention. So, and I personally believe, and this is part of our work group for the Athlete Brain Health Foundation, that using post-concussion syndrome can create a barrier to effective recovery. It's often perceived as pejorative. It blames the athlete or patient for not getting better. And certainly I've seen this in my own hospital system where it's like, oh, they have PCS, as if there's something that they're doing and they're not getting better and it's sort of hopeless. And I don't think that's fair to our patients. So the other important thing is it's really important to use the correct terminology. So if somebody has just had a concussion, the correct diagnosis is concussion, and then concussion follow-up, and then concussion sequela. Myself and many of my colleagues have seen people go to the emergency department immediately after concussion and come out of the emergency department with a diagnosis of post-concussion syndrome. That then gets carried in their medical records and is kind of like, oh, well, they're just not getting better. And that's not, again, that's not appropriate. So it's important to use the terminology correctly. And again, as I've said previously, post-concussion syndrome really conveys a sense of hopelessness. And we have learned more and more about the various factors that can be associated with symptom persistence. So it's important to focus on those. So the other issue I have with post-concussion syndrome is that I call it the red herring. And the classic red herring analogy is that there was a very old practice, and I think one of the Nordic countries, that if you really wanted to throw a hunting dog off at the trail of something, you would wipe a red herring across the scent path, and then that would distract them, and they would go off to something else. So, and of course, a red herring means to distract attention from something else. So when we think about post-concussion syndrome as a clinical red herring, it really results in misattribution, diagnostic errors, and misinformation by healthcare providers. So many symptoms are misattributed to concussion, and with misattribution, the patient ends up with an inadequate evaluation and treatment. Treatable symptoms and conditions go untreated, and this includes medical conditions. In our complex concussion clinic, we've seen people with diabetes, thyroid issues, and a number of other medical issues who those symptoms were becoming, a lot of fatigue and various other symptoms, but their providers were saying, well, that's just your concussion, when in fact there was another process going on. And these were people with significantly prolonged symptoms, and also whose symptoms were not following the typical trajectory of acute symptoms first and then tapering, but they started the taper and then their symptoms went up over time, and that's because something else was going on. And as I previously mentioned, post-concussion syndrome is often inappropriately diagnosed at the time of initial concussion diagnosis. And we still have the problem of overprescription of cognitive and physical rest, which causes isolation and inactivity, and then that can then become considered part of a prolonged concussion pattern, which is just the fact that this person's been isolated and they become very deconditioned. And particularly if you think about competitive athletes who used to very intense physical activity, and if they are held and told you can't exercise at all, that can create a lot of physical fatigue and just really feeling pretty badly. So it's really important to be aware of the research that We don't want anybody to go back into a contact sport or into anything that might cause them additional harm while they're recovering, but we want them to start to walk. We want them to move around. We want them to resume classes and get moving. So this new terminology, I believe, and my colleagues believe, is needed to drive improved care because we need a clinical term that emphasizes the importance of accurate diagnosis of the specific symptoms that are persisting after expected recovery, not just sports post-concussion syndrome without any clarity, but what specific symptoms are persisting so that those can be treated. And this is important because it also instills hope and sets a positive expectation for recovery. So again, the term that we've been promoting is persisting symptoms after concussion. It implies specific symptoms are persisting that require ongoing clinical management, calls for the individualized evaluation and identification of those specific symptoms, and uses active and optimistic language that implies that symptoms are not permanent and they are treatable. Also communicates that symptoms experienced after concussion may not be due only to concussion. Having a concussion is very stressful, and so the concussion can then result in some other issues that can be contributing to your symptom picture. So factors associated with persisting symptoms, and this slide is thank you to Dr. Russ Bauer, who's on the work group with me. Based on the general population, we know that what anybody brings to the table pre-injury can influence the likelihood of persisting symptoms after concussion. So older age at injury, premorbid mental health history, psychological distress post-injury, litigation, previous head injuries, abnormal acute neuroimaging, which almost always indicates a more severe injury, expectation of poor outcome, which is why hope is so important, extracranial injuries, and high initial symptom load. So again, with those extracranial injuries, that may be somebody who has an orthopedic injury that's very painful, disrupting sleep, disrupting their functioning. So, and then in terms of, I like to think of appropriate concussion management as precision care. So instead of a one-size-fits-all, here's how you manage folks, the importance of really understanding that individual. And so again, Grant Iverson and his colleagues at the end of their review said that the personal experience and reporting of post-concussion symptoms is likely individualized, representing the cumulative effect of multiple variables such as genetics, mental health history, current life stress, medical problems, chronic pain, depression, personality factors, and other psychosocial and environmental factors. And then Mickey Collins and his colleagues said that sport-related concussion is a heterogeneous injury that is characterized by a myriad of symptoms, variable clinical presentations, and recovery trajectories. And so I really like this slide to highlight that post-concussion syndrome, as I said, the symptoms are very nonspecific. So for all of you who've been on so many Zooms, and probably including today's WebEx, or just the stresses of trying to work from home, which pandemic brain, those symptoms are technically, any of us who have those symptoms would also meet the criteria for post-concussion syndrome, because you see they're very nonspecific. Having a headache, kind of just feeling lightheaded, concentration difficulties, a little bit of sluggish thinking, fatigue, and etc. And so again, these are very nonspecific symptoms, which is why Dr. Iverson in his study found that nearly a third of people without a concussion met the criteria for post-concussion syndrome. So, and in this review of multivariate models for MTBI, they looked at 26 studies that met their criteria, which that they were prospective, prognostic data at 1 month post-injury, and had at least 2 variables to predict symptoms. And there was no one model that predicted individual outcomes. But the most robust predictors were pre-injury mental health, acute post-injury neuropsychological functioning. So again, that's that high symptom burden at the time, right after concussion, early post-injury anxiety, and in this review, women tended to have worse outcomes. The severity of the mild traumatic brain injury had little predictive value. So I'd like to advocate that it's time to retire the term post-concussion syndrome because, again, non-specific, unclear timeframes, wide variability in the use of the term. It results in misattribution by healthcare providers. Does not provide helpful diagnostic or treatment information, and it can deny or delay helpful and appropriate treatment. It's not helpful to the patient, and it can convey a sense of hopelessness. So in terms of what is expected clinical recovery, this again is from the CDC, and for children with MTBI, they said 70 to 80% will demonstrate functional recovery by 1 to 3 months. Typically, it's about 7 to 10 days in healthy college-age athletes with no previous concussion history. But other factors may increase the length of recovery. So when you apply findings about athletes to the general population, it's important to keep that in mind. Typically, adults are going to have symptoms about 14 days. But if you have somebody who's older and has a lot of medical comorbidities, including things like diabetes or cerebrovascular risk factors, they may have a slower recovery. And then again, also older adults typically recover within 3 months. And again, medical comorbidities can increase the length of recovery. So the key is individualized concussion management. It is really important to have that really good clinical interview with your patient. And I typically ask about a lot of different symptoms, but then I say, what is the number one most concerning, most difficult symptom for you to manage that you have as a result of your concussion and that you most want help with? And that is very enlightening because they may have sort of emphasized one thing, but when I ask that question, they're like, this is the one thing. If this one thing could be better, that would be very helpful to me. And then you start to sort of tailor the areas for intervention. And a caveat here is that there's a lot of research going on, and there is some very sophisticated imaging that suggests that there may be a physiological recovery that is still going on after clinical recovery. And of course, that makes it difficult for all of us clinicians. And so currently the idea is that you really do want to emphasize that graduated return to activity that I showed you from Berlin, because you want a little bit of that buffer zone of getting somebody active and continuing to allow them time to recover and after they've said that they are symptom free. And so that graduated return to activity is really helpful with that. And so we're, of course, going to all be waiting for more research to help us better understand if there's a way we can identify complete physiological recovery before releasing athletes back to play. So I want to call your attention to a couple of really excellent resources. So one are the new resources that were posted on the CDC website. And these are evidence-based guidelines for pediatric MTBI. So if you work with children and adolescents, this set of tools is phenomenal. It talks you through and patients and providers through acute injury, what to know, how to manage. There are sheets that a primary care provider can print out and check off what kind of accommodations a child needs in school. There are informative brochures for parents that explain, here are the kinds of symptoms a child may have, here's what to look for, here's how you can help manage them at home. They're very user-friendly and they're easy to find, so that's an excellent resource. For adults, our friends up north developed the Ontario guidelines. These came out in 2015, and the newest edition is in dated 2018. And they used a modified Delphi process to identify 96 different recommendations for diagnosing and treating MTBI and persisting symptoms. And so they really emphasize at the beginning, just as Wiley Mittenberg did back in the late 1980s and 1990s, the importance of education and expectations, telling people what to expect after a concussion. It's extremely important to normalize symptoms, to provide reassurance and positive recovery expectations, that gradual return to activities and roles, and really stress management techniques, because again, having a concussion is stressful, and just reducing stress and helping with stress management also can improve that perceived sense of control for patients. And this is also a PDF you can get. You can Google it, and there are embedded hyperlinks throughout that take you directly to specific recommendations, and I'll show you an example in a minute. But when they talked on the section about persisting symptoms, they talk about being sure to really do a good differential about chronic pain, depression, anxiety, other medical and psychiatric comorbidities, and then reviewing prescription drugs, over-the-counter meds, supplements, alcohol use, and other substances. And then they list some differential diagnoses for persisting symptoms. And so what I want to do now is just talk briefly about some of the common factors affecting recovery. Some of these are the most common or the most problematic for patients. At least these seem to be the ones that are very distressing for folks. So if we look at headaches, headache is the #1 most common symptom identified after a concussion, which you can see here, and that can be very problematic. And so if these symptoms persist, that's where they may need to see a neurologist or somebody who can really help with a concussion. And this is where those Ontario guidelines that I mentioned are so helpful. So this is a screenshot of the Ontario guidelines, specifically around the issue of headache after concussion. And what you can see is that if the based on the patient's headache characteristics, consider these medications, so starting with over-the-counter, but being careful that they limit these to less than 15 days per month to avoid a rebound headache. But then it goes through that if they're migrainous in nature, you can use another group of medications. And they talk about the importance of avoiding or restricting narcotic analgesics. And then also that you might need to think about some prophylactic headache therapy. And if these post-traumatic headaches are not responsive to those first steps, referring to a neurologist, pain management specialist, or a concussion clinic. And then vision, this is sometimes seen as a little bit of a controversial area because there's some mixed research here on conversion insufficiency. So typically that is believed to be a disturbance of binocular vision that occurs after an impact and can contribute to eye strain, headaches, blurred vision. This is very common when patients say that they start to feel nauseous if they look at their iPhone or their smartphone or working on a computer screen, and they feel like their eyes are jumping, they have trouble with reading. This is when you may need to refer to a specialist who can do an assessment of functional vision and then provide some eye hygiene recommendations to patients and some recommendations about how to manage those symptoms while they recover. Vestibular dysfunction can be it's a small % of patients for whom this is an issue typically after concussion, but for those patients, they feel miserable because it's a very strong sense of vertigo, and this can be treated relatively easily with a repositioning maneuver to realign crystals in the inner ear. So you can see there that you can evaluate it using a Dix-Hallpike maneuver, and then it's called an Epley maneuver to reposition the crystals. And so typically this may be a physical therapist or somebody specifically working vestibular therapy or a neurologist who may be needed for this. So I want to switch gears and talk a little bit about anxiety here. And this is one of the most common changes after traumatic brain injury. So prevalence rates up to 70%. Having anxiety before a concussion or a more significant brain injury can increase the risk. And because social isolation can be increased after injury, that can contribute to the anxiety feeling worse. I almost always cite this study because I think it's so elegant. So it's Jenny Ponsford in Australia and her colleagues. And this was a prospective study in which they assessed and evaluated patients in the emergency department. So these were patients presenting with a mild traumatic brain injury or a trauma, typically a peripheral injury type trauma. And they were followed up at 1 week and 3 months. So they were assessed at the time of injury, 1 week and 3 months later, and had a variety of measures that looked at cognition, pain, pre-psychiatric history, current psychiatric symptoms, traumatic stress, social adjustment. And they found that the best predictors of post-concussion symptoms at 1 week was having actually had a concussion, being female, having a pre-existing psychiatric history, or having a high anxiety in the emergency department. And then the strongest predictor post-concussion symptoms at 3 months was having pre-injury physical or psychiatric concerns, but not having had the concussion. So at 3 months, what you're picking up is the pre-existing physical or psychiatric symptoms. And they went on to say, based on their research, that they thought really looking at those premorbid and coexisting psychiatric symptoms, especially anxiety, very important in predicting and helping treat post-concussion symptoms. So many of you may be aware of the TRACK TBI and TED studies, which is really it's transforming research and clinical knowledge in traumatic brain injury. It's a large-scale longitudinal observation study. And so they really, this is a much more recent study, looked at the longitudinal relationship of anxiety and depression to functional status after MTBI. And what they found is that depression and anxiety symptoms predicted functional impairment. So it wasn't that it was concussion and then the depression and anxiety, but from their analysis, depression and anxiety then predicted more prolonged difficulty in day-to-day functioning. And this was particularly strong when the head CT was negative, but less pronounced when there were intracranial abnormalities. And that's because if somebody does have a more severe injury, meaning abnormalities on imaging, depression and anxiety are less likely to be driving the clinical picture. And so they went on to say that their results may partially explain persisting symptoms in a subset of patients with MTBI, and again highlight the importance of assessment and treatment for mental health problems after MTBI. This is one of the reasons why the role of the neuropsychologist is so critically important in working with patients with concussion. That's true with athletes, but it's true of concussions from car accidents, ground level falls, partner violence, all the things that I kind of mentioned at the beginning of the talk, because there can be a mental health component that's tied into those cognitive concerns and some of the other symptoms. And so the neuropsychologist's role is very important. And I'm just going to show you 3 slides real quickly that are showing now all of the different factors that can be associated with a prolonged recovery. So both neurobiological and psychosocial factors can interact and create various different outcomes. And so this was from 2015, and then this came out around the same time and really said that with athletes and others who have concussion, you may have what they think of as trajectories. So basically a predominant symptom type, and that people may have different predominant symptoms types, ranging from migraines to anxiety to the visual symptoms, etc. Well, then it's gotten much more complicated, and this was a 2019 multi-author discussion of all the various factors that can be tied to recovery or slowed recovery after sport-related concussion. And you don't need to see all the fine print. It's just enough to know that there's a lot of factors in there, which again means so many different factors and variables can be associated with recovery or a slow recovery. So it's important to have that individualized assessment. And this is a really important, again, kind of a throwback to Wiley Mittenberg and his classic work. One of the things we often see is that people after concussion say, I must have terrible brain damage because I can't remember where I parked my car or I lost my keys. And so part of Wiley Mittenberg's education and expectancy model is to really provide information that that's normal, that we all do those things to some extent, but we tend to really pay attention and to worry about it after we've had a concussion. Whereas when we haven't had a concussion, we're like, oh, I'm just stressed out today, or I'm not paying attention. And so it's really important to provide some corrective education. And again, I just want to say one word about insomnia, which is very common to have sleep disruption after concussion. And sleep disruption can in itself as you all know, cause cognitive problems. So reduced reaction time, cognitive processing speed can make you feel more depressed and anxious. And so really addressing sleep is an important part of recovery. And so what kinds of things do we do in our acute concussion clinic? In addition to providing that individualized clinical management, we provide a lot of education and setting the positive expectation for recovery. So we tell them their symptoms are typical, we expect these, it's normal for them to feel poorly at first and to continue to get better. We stress that they will get better. And then we start to talk through their symptoms and give them recommendations that they can use. So for instance, we talk about sleep disturbance and pain and we recommend a lot of phone apps. Many of our patients do have smartphones, but we check because we have some folks who live in outlying areas who either don't have Wi-Fi access or otherwise access to technology. And so for them, we may print out recommendations and give them to them in paper form. We talk a lot about the importance of anxiety and stress reduction, and I promise we don't get any compensation from these app companies, but these are the ones that I think are very, very helpful, and people like them. And so Breathe to Relax, Headspace, Calm, all of those can really help with teaching ways to manage anxiety and to calm. And we directly address anxiety in clinic. If somebody says they have a history of anxiety, then we say, because you have a history of anxiety, you're more likely to have a more complicated recovery, and here's why. The symptoms of anxiety can feel just like a concussion. And so if you're recovering and then you're in a situation, you feel like your concussion is getting worse, that's likely your anxiety. And then we explain that concussion symptoms, as you progress and your symptoms remit, you're not likely to have a dramatic worsening of your symptoms. It's likely a reaction to or worry about your symptoms. We also provide a lot of education on cognitive functions, the difference between attention and memory, and how a lot of factors can affect cognition. And then we give some strategies for attention while they're recovering, things like putting a whiteboard in their kitchen, using their smartphones with alarms, etc. So I'm going to go through this case very quickly so I can try to keep us on time. And this is an important case, not to scare you all about concussions can have something super scary going on, but because this is a really good illustration of concussion as a red herring. So this was a 17-year-old male who had a football concussion about 4 to 5 weeks prior. His initial symptoms were headache and double vision, and he had no complicating premorbid factors. He was clean as a whistle. He had a good mood, no mental health history. He slept well. He was actually a very strong student. He'd been appropriately held from his sport, and his acute concussion headaches had mostly resolved, so they followed that expected trajectory. But then he was referred to neurology because he started saying he was having persisting symptoms of not feeling back to normal and random thumping in his head with movement. And prior to being referred to neurology, he had been diagnosed with post-concussion syndrome by his primary care provider. So, as you know, that should immediately raise some red flags. And it was actually an athletic trainer who has worked very closely with us, who was knowledgeable, who said, this doesn't make sense. The fact that his headaches remitted and he was starting to do fine and he followed the traditional, expected recovery, and then all of a sudden he started having these other symptoms. She was the one who said, this young man needs to see neurology. So the neurology exam revealed significant eye movement abnormalities. And our neurologist said, I'm concerned because this is much more atypical than we usually see for simple post-concussive eye movement problems, and concerned for intracranial pathology. They were concerning for cerebellum, and she noted a decreased upgaze, which could be indicative of brainstem pathology or increased intracranial pressure, recommended an MRI, and there were positive findings on MRI. So that's a germinoma. And the MRI report revealed an obstructive hydrocephalus with reverse cupping of the optic nerve heads consistent with raised intracranial pressure. And so the neurosurgery, he was seen by them, and they did an intervention surgery, and the pathology did reveal it was germinoma. And he had his hydrocephalus symptoms resolved, and he had chemotherapy and went on to be a very successful college student. But again, what's really important is when symptoms don't follow that expected recovery, something's not right. And so it's important to have a new evaluation to see what's going on. So let's retire post-concussion syndrome as it's not a helpful diagnosis. And again, it delays or denies appropriate treatment. It's important to instill hope. And again, for those of you who are not familiar with Wiley-Mittenberg's classic literature in this area, the manual that he developed in the 90s, early 90s, I believe, is so helpful because it talks about this positive expectations. So it's important for our patients to have hope after concussion. Hope is correlated with improved performance and greater psychological well-being. It's a protective factor against chronic anxiety. It's a motivational factor that sustains action, and it helps people move forward through their recovery. And it's future-oriented and motivates individuals to maintain their positive involvement in life, regardless of any limitations, which may be their concussion symptoms as they're resolving. Those particular statements all came from positivepsychology.com, but I think instilling hope is very important because there's so much misinformation in the media. And so in summary, most concussions resolve. If they don't, identify specific symptoms for treatment or referral. Be mindful of using the term persisting symptoms after concussion. Be mindful of the red herring. It's not always the concussion. There could be something else going on that's explaining the symptoms. And our goal is to return our athletes and patients to school, sports, and their life. So that's it. And I'm happy to take a few questions if we have time.
Thank you so much, Dr. Broschek. That was a wonderful presentation. I had several viewers who agree with your terminology discussion. So we have a few questions about some of the symptoms, some of the pre-existing conditions and recommendations. So starting with the first one, this person brought up pain that athletes can experience and endure as a regular part of their sport. And you also mentioned some chronic pain as well in the literature. Do you see a lot of pain in your clinical work, and what role do you think it has in recovery for athletes and or non-athletes?
That's an excellent question, and I sometimes co-present with my friend and colleague Stan Herring, who is a physician in Seattle. For those of you who've heard of the Lystedt Law, he was Zachary Lystedt's physician, and he uses chronic pain as an injury as a model for understanding persisting symptoms after concussion. And so I think it can be very much a factor. So it's really important to really look at concussion, and if pain is also, it's a non-concussion related pain is occurring for the athlete, to make sure that is addressed, because that can certainly present as very much like the concussion symptoms.
All right. Next question is about terminology related to the use of MTBI versus concussion. Do you have any thoughts on potential benefits or risks for continuing to use the term concussion versus MTBI?
It's a great question, and I wish I had a clear answer, and it's kind of gone all over the place. And I can tell you that when my mentor and I, in the early 2000s, were trying to get people to pay attention to concussion, we would stress all the time, this is a mild traumatic brain injury, which it is, because we wanted people to understand that it needed to be taken seriously, to be addressed, to be managed. But then once the paradigm shifted dramatically to the other side, and the media got on board and said that if you have a concussion, you can have this horrible, devastating outcome, we tended to start using the word concussion because people would say, I just had a traumatic brain injury, and that's what they would hear, and they would perceive themselves to be very permanently disabled. And so a concussion is a mild traumatic brain injury. I tend to try to explain some of that to patients. So it's a great question. I don't think we have a clear answer, and I think it kind of depends on what is most helpful in that individual patient encounter.
That certainly makes a lot of sense. Thank you for the history there as well. For adult clients, do you have any advice based on the literature for returning to or avoiding substance use such as alcohol or marijuana?
So not necessarily evidence-based. I essentially suggest that people not use alcohol or marijuana while they have symptoms, because if their symptoms are clouded cognition, well, alcohol and marijuana is not going to help. And so I typically say that I really recommend that they try not to use those. Sometimes I'm working with college students, and I would say, like, look, if you're going to have a drink, just at least try to have not more than 2 instead of 12 when you're recovering. But of course, it is most beneficial if they don't use any until they have fully recovered, and trying to really talk with them about the reality of that, and trying to at least make sure it's really minimal.
Definitely. So I do want to be mindful of your time. I know it is at the hour mark. We do have some additional questions, but we can always have a follow-up later on if you are not able to stay on.
I'm fine to stay on a few more minutes.
Okay, perfect. Thank you. The next question is about recommendations for returning to driving. Do you have any recommendations about that, or are there symptoms that you might see that would be particularly problematic for driving safety?
You know, that's a really important question, and one that has really been kind of missed by a lot of clinicians and researchers. There's more research on that, and the answer is, if somebody's symptomatic, they really shouldn't be driving. Because they're having trouble tracking information. They may have visual tracking issues. And so we tend to recommend that they not drive while they're symptomatic. And sort of an unexpected benefit of that is that may also help motivate people to make sure they're recovering more quickly and addressing those factors so that they can return. But particularly with new drivers like adolescents and young adults, it's really important to tell them that if they're highly symptomatic, they really should not be driving until they've recovered.
Right. So this is a question that's come up a couple of times in the chat. So recommendations, or when you see a patient who comes back later and is just still discussing symptoms months or even several years later, do you often recommend follow-up referrals to neurology or neuroimaging, or discussion of what is typical and what is atypical, or how does that kind of look in your practice?
So often those patients come to us for full neuropsych, and I think that is a very important role, because we can do a clinical interview as well as the formal testing and really get a sense of what's going on. And the interview, if somebody describes that they recovered and they were doing fine, and then their brain injury got worse again 1 year or 2 years later, then that's a flag that there is something else going on. And so part of that is getting a sense of what kinds of symptoms they're reporting. Sometimes I'll say that I think they need to see neurology, and I'll tell the neurologist I think they may need to consider imaging, because it really sounds like something more focal. Or sometimes, again, it could be some other medical issue like thyroid disease or diabetes, a number of different things. So I think, again, the answer is it depends, and that's because it's individualized, which is to really see what that symptom trajectory looks like, what the specific symptoms are, and then kind of based on our neuropsych, figure out which is the most appropriate provider for either further evaluation or treatment.
Excellent. One final question before we let you go. So this one is specific to athletes and those who may be very eager to return to play. Do you typically cite evidence of prolonged outcomes or anything in discussing the gradual return to play with them?
Absolutely. So I think several things. One is, cite the Berlin guidelines. This is what we do with athletes. And so sometimes high school athletes in particular, you know, you can say this is what the NFL uses, this is what, you know, all the international athletes use. But absolutely, it is really important to tell athletes that if you go back while you're still symptomatic before you're fully recovered, chances are you may end up with a much more complicated recovery and be out actually a longer period of time. So if they want to be best to themselves and take care of their own health and be best to their teammates, they need to follow the recommendations of their healthcare providers.
Definitely. I think that's a good way to say it for sure. Well, thank you so much, Dr. Broschek. This was wonderful. And the recording will be on the website later this week. And everyone join us next week for our discussion on advocacy and neuropsychology. Thank you so much.
Thank you.